today's talk be more theoretical than cases. So let's start. I'm going to cover the adult type of diffuse gliomas, which are, as I told you, are two types: the IDH mutant and IDH wild type. So today I am covering the IDH mutant type and IDH wild type is the glioblastoma, which is the commonest tumor. We are going to hold a separate class for GBMs that Dr. Gaurav is going to take on 29th of May. On 28th of May, Dr. Anila will cover the circumscribed gliomas. We will post the new review of schedule on the WhatsApp group. So this is the WHO 16 classification. As you can see, there were so many types and subtypes in the gliomas, and 2021 classification has simplified that into a few entities for us to remember, and they have also classified them into adult type and pediatric type. So another change that we have done in our schedule is combine the low grade and high grade pediatric tumor into one class. So this is the IDH mutant type of gliomas. That is, one is Astrocytoma, another is oligodendroglioma, and the IDH wild type, which I am continue to repeat, is all IDH wild types are we don't believe or we don't classify IDH type into grade 2 and 3. They are glioblastomas. So the first IDH mutant tumor or IDH mutant glioma is the Astrocytoma IDH mutant. So by definition, this is a diffusely infiltrating tumor, either IDH1 or IDH2 mutant. Frequently, what we must see is the ATRX and P53 mutation, and there has to be absence of 1p19q codeletion. Rupali Kulkarni, can you please mute yourself? Terminology which should never be, which is not allowed by WHO, is the diffuse astrocytoma IDH mutant, anaplastic astrocytoma IDH mutant, and glioblastoma IDH mutant. This terminology has to be discarded. And the terminology that is used is Astrocytoma IDH mutant grade 2, grade 3, and grade 4. For us to be accurate and for us to be recognized in the professional fraternity, we must follow the terminology as per the guideline provided by WHO. It is easy to publish, to discuss when we have when we follow the standard guideline of nomenclature. So this tumor is can be found anywhere in the brain, including brainstem and spinal cord, but most commonly it is a supratentorial tumor, and that too is found within or around the frontal lobes. As the IDH mutant and 1p19q co-deleted oligodendroglioma also occur in this location. So frontal lobes are very preferred site for IDH mutant tumors, gliomas to occur. Genetically, different IDH mutant astrocytoma have been described in infratemporal compartment. age is between 30 to 40 years, and the median is 38 for grade 2 and 3. For grade 4 astrocytoma IDH mutant, little older age, they occur around 50, and male is more than female. Ratika Chauhan, please mute yourself. These tumors are mostly sporadic, but have been associated with leaf promenade syndrome, which is a p53 germline mutation syndrome. This syndrome shows IDH mutant gliomas, but the mutation of IDH which is seen with this syndrome is different. That is, this is a R132C mutation, and the most common mutation in sporadic IDH mutant glioma is IDH1 R132H. Remember this is the IHC antibody that we use, and this mutation is present in 90% of tumors. The IDH mutant gliomas are not seen in any other diffuse glioma predisposing syndromes like neurofibromatosis, neurofibromatosis 1, or in Port syndrome, or with melanoma, astrocytoma syndrome. The IDH mutant gliomas are not seen in any other hereditary or predisposing syndromes other than the Lee-Fromini syndrome, that is the p53 germline mutation syndrome. The IDH1 mutant astrocytoma in children and young adults are associated with a germline mismatch repair gene mutation. So now it is recommended that all IDH mutant astrocytoma occurring below the age of 30 should be tested for MMR, that is mismatch repair gene, otherwise known as MSI. The IHC is freely available. We do it for colon cancer, and we do it for endometrioid carcinoma. So this should be a routine for IDH mutant astrocytoma occurring in children and young adults. And this is one type of IDH mutant astrocytoma in which we can give some hope to the patient. So the IDH mutant glioma, how do they cause tumor formation? So as we know, this IDH is an enzyme of the Krebs cycle, and when there is mutation, what I'm going to tell you is a very simplified representation of the pathogenesis. So when there is mutation of IDH, this is an enzyme. It causes production of a oncometabolite, which is a 2-hydroxyglutarate. This oncometabolite causes DNA methylation and methylation of histones. When histones are hypermethylated and when the DNA is methylated, it results in production of the CPG angle. This is the full term of this is the full term of this is CPG island methylator phenotype, or also called GCMP, CIMP. So when this happens, when there is DNA methylation, any kind of methylation, what it does is it extensive hypermethylation in DNA causes the silencing of genes. It stops their functioning. So when this happens to the gene in the promoter region, many many genes are silenced, which help in expression of many important cellular differentiation factors. And as a result, when the differentiation of cells stops, they remain in a primitive state. So the primitive state, or the stem cell, they acquire a stem cell like state. And these cells have a capacity of self-renewal, and they proliferate and cause a tumor formation. So when there are these islands which are formed because of the DNA methylation, they acquire this phenotype, and when they acquire this phenotype, they can produce glioma, or gliomagenesis can happen in a cell which is, or in tissue which has IDH mutation. So the initial alteration that happens in an IDH mutant glioma is the IDH mutation and production of these islands. 1 minute. Ashok, Ravi ke phone pe phone karo. मैं class ले रही हूँ. So when there is IDH mutation, as I have explained to you, that we develop these CpG island methylator phenotype, and they predispose or they produce a cell which is a precursor of glioma cell. And on top of this initial alteration, there are two ways this tumor can progress. When the secondary alteration is in the form of 1p19q codeletion, or TERT mutation, or CIC mutation, that results in the formation of an oligodendroglioma. And when this is in the form of, the secondary event is in the form of p53 mutation or ATRX mutation, it results in the formation of astrocytoma. And when there are tertiary events, they result in upgrading the tumor into grade 3 or grade 4. So the common IDH mutation which are found the most common is IDH1 R132H. It is seen in more than 90% of the astrocytomas and oligodendrogliomas. And in addition to this mutation, the IDH1 has some few other mutations which account for less than 10% of the total mutations in IDH mutant astrocytoma. And in that 10% also include IDH2 mutation, and the most common IDH2 mutation found is R172K. When this hypermethylation or DNA methylation is taking place, this extensive hypermethylation of the gene promoter region also involves the MGMT, which is an important promoter region gene, and this is responsible, or it encodes for the DNA repair proteins. When normally the MGMT, when it is not methylated, what it does is it helps in deactivating or neutralizing the alkylating agent actions. So when this gets methylated, the effect of alkylating agents cannot be neutralized, and the drug becomes ineffective. So when it was normal, the drug was ineffective. When MGMT gets methylated, then the drug becomes effective. And this is more pronounced or more effective when this MGMT methylation is, promoter methylation is accompanied by loss of one copy of chromosome 10, on which the MGMT is located. So this is what MGMT is all about. Mutant cytoma also have class-defining mutations of P53 and ATRX. The TART promoter mutations are seen in oligodendroglioma, and they are seen in glioblastoma IDH wild type. ATRX mutations and TART mutation both are mutations in the telomere region, and but they both are mutually exclusive. That is, if there is ATRX mutation, the TART mutation will not happen. And when there is TART mutation, no need to look for ATRX mutation. These are some of the alterations which are associated with the tumor progression. So, and the most important being the CDKN2A and or 2B deletions, which are associated with shorter survival. And similarly, there are other mutations which have been, which are seen when the tumor upgrades. This is the list of those mutations. Because we are doing NGS, in many of the doctors are asking for NGS, and more information is we are receiving about all the mutations which are seen, if not in majority of IDH mutant gliomas, but in minority. And we are at least now documenting them, and maybe some of the patients can be helped by finding a target against one of those mutations. So briefly on the histopathology and grading of IDH mutant gliomas. I have shown you pictures of in the last class of the morphology and basic IHC of astrocytomas. So this is these tumors show moderate cellularity with cyst formation, and the grade 2 tumors show less than 4% of key labeling index. Grade 3 may show normal, they have areas which are of moderate cellularity, but you have foci which are more cellular. And when you look at the cells, they are more anaplastic and they do have more mitosis. Even 2 mitosis per specimen is adequate enough to call them as grade 3. And they have a higher rate of mitosis. This is about double the number that we have seen in the grade 2, that is 8 to 10%. And this is the grade 4, where you get to see higher cellularity, more mitosis, and you see more anaplasia. There are more mitosis here. You can see this is mitosis, mitosis, mitosis. There are more mitosis, more anaplasia, high cellularity. And what we look for is the endothelial proliferation and necrosis. Even if the mitosis and cellularity are not there, but you see endothelial proliferation and necrosis, it will make it grade 4 astrocytoma. And these grade 4 show very high mitotic activity and key labeling index. So grade 2 astrocytoma are diffusely infiltrating. They are IDH1 or IDH2 mutant. They lack anaplasia. Mitotic activity is not detectable. microproliferation, microvascular proliferation and necrosis are absent, and CDKN2A and or 2B deletion is absent. So this is grade 2 IDH mutant astrocytoma. In grade 3, again, diffusely infiltrating IDH1 or 2 mutant, focal or diffuse anaplasia, significant mitosis, but no necrosis or microvascular proliferation, and no deletion of CDKN2A or 2B. If there is microvascular proliferation and or necrosis, it becomes grade 4. And even in the absence of microvascular proliferation and or necrosis, if there is CDKN2A2B homozygous deletion, then also it becomes grade 4 astrocytoma IDH mutant. Mitosis is very important. I spoke about importance of standardizing the mitosis count and the key 67 labeling index counting. Each of the pathologists should learn it and use it. The mitosis, more than 2 in any specimen are associated with a poor shorter survival. Hence, any specimen with 2 or more mitosis is grade 3. Key 67 labeling index, grade 2 is, these are not absolute figures, but this is generally what is seen. WHO does not insist on this figure that this is what is the standard, but this is a general experience of most pathologists. Grade 2 usually show less than 4% of key index. Grade 3 shows 4 to 10%, and grade 4 usually shows more than 10%. However, in grade 4, mitotic count or key 67 labeling index becomes immaterial if you see necrosis and microvascular proliferation, and also if you see co-deletion of CDKN2 to homozygous deletion. Both these things will make it grade 4. So the WHO now gives you diagnostic criteria for diagnosing astrocytoma IDH mutant. Essential is that it should have a diffusely infiltrating morphology, IDH1 or IDH2 mutation, and loss of ATRX expression. These are essential. And what is this? I am not doing it. Who is doing this to my screen? Exclusion of exclusion of 1p19q co-deletion. These are essential events. Desirable is that you see p53 mutation, which is the surrogate of which is the IHC, that is strong nuclear expression of p53 in less than, in more than 10% of tumor cells. And if methylation profile is of astrocytoma IDH mutation mutant, and astrocytic differentiation on morphology. If we see this, this is desirable, but essentials are diffusely infiltrating glioma, IDH1 or IDH2 mutation, loss of ATRX expression, and lack of 1p19q co-deletion. The important diagnostic molecular markers that we need a little bit of information, because you get short note on this in exams, especially pathologists. There are many signature molecular characteristics of IDH mutant astrocytoma that can be demonstrated by immunohistochemistry. The first one being the IDH1 R132H by immunohistochemistry. This is a highly sensitive and specific marker. The IHC positivity is a strong evidence of IDH mutant glioma. You don't need to go for sequencing if you get a positive IHC. This is so good. The IDH1 staining is a critical initial test for classification of gliomas. This helps you in differentiating a reactive gliotic process from glioma, grade 1 tumors from grade 2 tumors, non-glial tumor from glial tumor. If you have IDH positive tumor, then it cannot be, this is a mutant IHC. So it is a marker which marks the mutation. It cannot be seen in normal or reactive cells, and it is not seen in any other tumor which does not have this mutation, and it is not seen in non-glial tumors like neurocytomas or pilocytic astrocytoma, all which make a differential diagnosis on pathology. So this is a very important IHC which is the R132H variant accounts for about 90% of all supratentorial IDH mutant astrocytoma. Infratentorial gliomas are rare, and 80% of them have non-R132H mutations in IDH1. Gene sequencing is recommended if the IHC is negative to detect non-R132H mutations and for IDH2 mutations. We do not have a IHC for IDH2 mutation. With negative IHC for IDH1 in grade 4 gliomas above the age of 55 years, sequencing need not be done because we know that majority of grade 4 gliomas at this age and above this age are IDH wild type. So coming to P53, this is in IDH mutant glioma, strong diffuse expression of P53 is a surrogate for P53 mutations. The P53 mutation supports the diagnosis of IDH mutant glioma. This mutation can express as overexpression of nuclear staining or as a complete absence of staining in nonsense mutations. Strong immunostaining in more than 10% of tumor nuclei correlates with P53 mutation in IDH mutant glioma. Third is ATRX. This is an inactivating ATRX alteration. This commonly occurs in P53 mutations in IDH mutant astrocytoma. These two accompany each other. These often result in truncated protein and abrogated protein expression, leading to loss of nuclear ATRX expression. ATRX positivity in endothelium and in the entrapped neurons serve as a positive internal control. Loss of ATRX expression is not exclusive to IDH mutant astrocytomas. They are also seen in H3 altered diffuse gliomas and occasionally can also be seen in IDH wild type astrocytoma. More than 90% of supratentorial astrocytomas show ATRX loss, but less than 50% of infratentorial gliomas show ATRX loss. When in a IDH mutant by IHC, and by IHC, ATRX is lost, that is mutant on IHC. It obviates the need for doing FISH for 1p19q codeletion. That means that we have proven that it is an astrocytoma and not an oligodendroglioma if there is ATRX mutation. Rarely, tumors can show dual genotype. That is, this is seen in two ways. One is when you see two different areas. One is clear-cut oligo, which shows 1p19q codeletion, and one part is clearly astrocytic on morphology and shows ATRX loss. The other way is that the whole tumor is uniform morphology but shows both ATRX loss as well as 1p19q codeletion. I have not seen such a case in my almost 20 years of practicing neuropathology now, but people have reported. And when you see such a case which is showing oligo and estro differentiation, that is oligoastrocytoma, this entity has been taken out of WHO classification. And when you see this morphology or this evidence, genetic evidence as well as morphological evidence, this should accompany a designation of NEC, not elsewhere classified. This tumor occurs, the prognostic factors which gives it a good prognosis is younger age, good gross total resection, poor shorter survival when there is residual tumor. The survival in grade 2 tumor is more than 10 years, that in grade 3 is 4 to 10 years, and grade 4 overall survival is less than 3 years. So any questions in astrocytomas? So we continue for oligodendroglioma. Again, this is a diffusely infiltrating tumor which shows IDH1 and IDH2 mutation and 1p19q codeletion. This is either grade 2 or grade 3. We don't have grade 4 in oligodendrogliomas. Terms which are not to be used is anaplastic oligodendroglioma. We call it oligodendroglioma, IDH mutant, 1p19q codeleted, and grade WHO CNS grade 3. It also shows a clear-cut frontal lobe predilection, and it is rarely seen in children. You should be very cautious of diagnosing oligodendroglioma in children. Most tumors are sporadic, and oligodendroglioma generally do not show any known hereditary association with known hereditary syndromes. This tumor has a very characteristic profile. It shows missense mutation in IDH1 and IDH2 combined with whole arm 1p19q codeletion. The IDH mutation, which is seen, as I am repeating and again and again, is more than 90% show R132H mutation. Less than 10% show non-R132H mutation in IDH1, and IDH2 mutations are seen in less than 10% of cases. 1p19q codeletion has to be whole arm deletion because partial or incomplete loss is not acceptable for the diagnosis of oligodendroglioma. Partial or incomplete loss is seen in IDH wild type glioblastoma. TERT promoter mutation, majority of oligo show TERT mutation, mutation, and however, the oligodendroglioma occurring in teenage lack Idh mutations. Another mutation which is commonly seen in more than 70% cases of oligodendroglioma is CIC mutation, and mutation in CIC, and this is located in 19q at 13. This CIC mutation, they act in conjunction with IDH mutations and result in unregulated production of oncometabolite, which is 2-hydroxyglutarate, and this causes DNA methylation, and the same pathogenesis is supplemented by CIC mutation. When the tumor progresses, we see that grade 3 tumors have a lot more mutation than grade 2 mutation, and also they oligodendrogliomas also when progress show CDKN deletions, and but this is seen in less than 10% of cases. Other mutations which are associated with progression are PIK3CA mutation and TCF1Z mutation. This is the same pathogenesis that I have already explained to you in detail, and this hypermethylation, as it does in Estrocytoma, also does it in oligodendroglioma, causes DNA methylation and stops the function of oncogenes, tumor suppressor genes. Sometimes good, bad things are stopped, and in addition to those bad things is some good thing, that is tumor suppressor activities are also stopped, and by silencing many of the needed genes and result in tumor formation. Histopathology of oligodendroglioma is very characteristic. We all, many descriptive terms are used in describing the pathology of oligodendroglioma. Like this kind of clearing around the nuclei is called fried egg appearance. And this is actually an artifact of fixation and processing. And this is not seen in frozen sections, and it is also not seen if the tissue is processed very fast. So this is a characteristic appearance. The nuclei very round, show very little variation, and it has a very delicate vasculature. Another thing is that is called chicken wire vasculature. All these delicate capillaries, branching capillaries you see. The other very characteristic feature that is seen is this mineralization of the tumor. These psammoma bodies or calcification are seen. This is also a characteristic feature of oligodendrogliomas. Another is when it becomes higher grade. Another thing which is seen are these microcysts sometimes have mucinous material. This is also a feature that is seen. It can also be seen in Astrocytoma, but more commonly seen in oligodendrogliomas. When this tumor acquire higher grade, the nuclei become more anaplastic and more mitoses are seen. You know, in this field itself, only 3 mitoses are seen. And this is IDH and this is ATRX. They also can show these plasmacytoid appearance, and this is called, these are mini gemestrocytes. This is the characteristic vasculature that is seen in oligodendrogliomas called chicken wire vasculature. And this mini gemestrocytes can sometimes they make large areas in oligodendroglioma. Again, IDH mutant, ATRX retained, P53 wild type. Another characteristic feature that is seen in oligodendroglioma is this subpial aggregation of tumor. In oligodendrogliomas, mitotic grade 2 tumors, mitotic activity is low or absent. And Ki67 labeling index is less than 5% in grade 2, and it is more than 10% in grade 3. Mitotic count is 2.5 mitosis per millimeter square, which is equivalent to more than 6 mitosis per 10 high power field. If seen, it will make it a grade 3 oligodendroglioma. The grading depends on cellularity, cytological atypia, mitosis, microvascular proliferation, and necrosis. You see any of these features, it will become a grade 3 oligodendroglioma. And if there is a homozygous deletion of CDKN2A or 2B, again it will become grade 3. But this is only seen in less than 10% of cases. The immunohistochemistry which is required is IDH, ATRX, P53, GFAP, olig, and Ki. Oligodendrogliomas can express a lot of antibodies, including S100, SOX10, MAP2, myelin basic protein, synaptophysin, you name, and you can, you will find the reports showing a positivity in oligodendroglioma. But these are of no diagnostic use in oligodendroglioma. There are many mimics of oligo, which include demyelinating tumor, reactive gliosis, non-glial tumor like neurocytoma, DNET, that is dysembrioblastic neuroepithelial tumor, pilocytic astrocytoma, clear cell ependymoma, and even metastasis can mimic a oligodendroglioma. And a simple one stain, if you have option of doing just one stain for differentiating these differentials from oligodendroglioma, is IDH1 IHC. This I have already said that if you have NOS, unless you do 1p19q or you do IDH or you do the proper IHC workup and proper molecular workup, if it is not done, and if it is you did but it was not successful for any reason, you can only call it histomorphologically oligodendroglioma NOS. And oligoastrocytoma neck, I have already explained with the astrocytoma. So in these two situations, and in this situation, NEC is designation is given because WHO does not classify oligoastrocytoma anymore. The WHO criteria of diagnosing oligodendroglioma are listed here. What is essential is the infiltrating glioma with the IDH mutation, combined with a whole arm deletion of 1p19q. Desirable is retained ATRX, TERT mutation, and if you have it, then methylome profile of oligodendroglioma. Grade 3 glioma has median survival of, when the chemotherapy, and there were not many options for treating brain tumors. The grade 3, the survival was much less, but with the there are now many prospective studies in which patients have been treated with PCV and with along with radiotherapy. The median survival of grade 3 oligos also is more than 14 years. The clinical features which which give it a better prognosis is younger patient, frontal lobe location, seizures at presentation, and high Karnofsky score. How do you pronounce it? Okay. Surgery, and on surgery, gross total resection has been achieved, then it also gives it a good prognosis. The histological feature, which if high grade features are there, then poor prognosis. The difference between tumors with high grade features is very significant. Grade 2 and 3, that is grade 3 survival is only 127 months and grade 2 is 205, 205 or 127. Those tumors which have a key index of more than 15% have shorter survival, and those tumors which show deletion of either of 2A or 2B also show poorer prognosis. This I have already repeated many times. So finally, if you have a diffuse glioma, do IDH1. If it is mutant, do ATRX. If ATRX is absent, do CDK and 2A, 2B. If CDK, 2A, 2B are retained, there is no deletion. It is an Estrocytoma IDH mutant grade 2 or 3. If there is homozygous deletion of CDK and 2A, 2B, then it becomes an Astrocytoma IDH mutant grade 4. If ATRX is retained, do 1p19q fish. If it is non-deleted, again we come back here. And if it is co-deleted, it is an oligodendroglioma, IDH mutant, 1p19q co-deleted, WHO grade 2 or 3 based on your morphology. Here in this, the histones are done right after doing everything, but what should be done by now, irrespective of the age, because we are seeing histone mutations. Even I think recently we diagnosed a 53-year-old adult man with an H3K27 glioma. So if it is IDH wild type, look at the we will look at the histology in the first go itself. When you see microvascular proliferation and or necrosis, it becomes a GBM or glioblastoma IDH wild type WHO grade 4. If there is on histology, you don't see all this, you have to undertake the molecular characterization. That is, you do the TERT mutation study, EGFR fish, and you do fish for gain of 7 and loss of 10. If any of these markers are positive, it becomes a grade 4 IDH wild type glioblastoma. And if none of this is found, and you must include in your panel H3K27, M and ME3 plus H3 G34 for hemispheric gliomas. So you include this and you will find that you will sort out majority of your cases. Thank you. This was a very theoretical lecture, but I think this was required because in CNS, most often the question come from this topic.
Hi, ma'am. Thank you. Yes, I agree on all the points. And of course, very insightful presentation. It cleared a lot of my doubts. Usual challenge that we face, ma'am, is like the flow chart that you had shown in the last. So you find the morphology first, then we go for the IDH. Sometimes we need to do an IDH sequencing also, and then go for the further molecular test. So I think the turnaround time is a big challenge, and sometimes exhaustion of the of combining all the steps, the turnaround time, the final report. So it takes a lot of time sometimes, and the second challenge is sometimes the tissue also gets exhausted. So we are also in talks with the lab so that we can combine various panels and get a comprehensive report ready. So that is one thing. Okay, so there is a question here. Maybe you can take up this question first, and then maybe I'll ask one or two questions. From Jayanti Datta, is CDKN2A oblique B?
There is supposed to be an IHC, but I don't think it is that good. In fact, CDK and 2A, 2B, even on molecular tests like fish and by PCR gives a problem. But I would say that many people, especially institutes who have like AIMS and NIMHANS, they have all the three technologies, and I think they have abundant CDK and 2A, 2B by IHC, and they depend on fish more. And if they have doubt, then go for PCR. So for CDK and 2A, 2B, the preferred methodology is fish.
Ma'am, sometimes we also see a discordant report, like suppose if it has been reported in morphology oligodendroglioma, but we see this co-deletion negative, 1p19q. So how to proceed there?
We believe you see, yesterday also somebody asked this question. Important is that we must make sure that the quality of the molecular test or the fish being done is has a good validation and has a good quality control. And if we believe that the test being done with good quality, then we have to believe the molecular test. Irrespective of morphology, if the tumor does not show 1p19q co-deletion, it is not an oligodendro. By definition, we cannot call it oligodendroglioma.
Then for clinicians, it's important because if we see oligodendro, if we see a co-deletion, then it helps us to decide the chemotherapy. Like the PCB regimen works for the patient who have this co-deletion positive, irrespective of what we see in the morphology. So that is why the report positivity has some treatment bearing, and that was the reason.
We don't diagnose oligo without the 1p19q.
Okay, that makes sense.
We call it histomorphology favors oligo. Yesterday I showed a case where we wrote that this is a histologically looking like oligo, but the IDH is wild type. The IDH1 R132H is wild type. We did not call it oligodendroglioma. We waited for the molecular reports to come back before we diagnosed it to be oligodendroglioma and glioma NEC. That too because it has the IDH was wild type even on sequencing, but it had 1p19q co-deletion and it also had third mutation. So probably this case deserve a methylome profiling.
Yes, sir, I agree. There's another question. There are two questions actually. Maybe you can take them one by one.
So Wasim Kitab is saying, how is IDH mutation linked to guanine phosphate cystosine island methylation? I think this is same, when the this is the oncometabolite which results in DNA methylation, and how that detailed process, how many types of enzymes are blocked, all that I don't think I can go into all that because that is a lot of basic biochemistry which needs to be discussed. I don't have the time, Dr. Wasim. Maybe I can refer you some of those articles, which even our own this WHO book gives it very nicely. And many articles, a little older articles, 208, 210, 2010, 11, they give it in detail. Is the approach different from infratentorial gliomas, considering many of them do not have actually infratentorial oligodendrogliomas are very rare, and I don't think many of us have any such a great experience of treating infratentorial glioma. But I think Priya can give you a better answer on this. If you have an infratentorial glioma.
No, ma'am, yes. Very few. I agree. Very few. Very, very, very few. We see very few infratentorial gliomas, and we always recheck what exactly is the diagnosis. And yes, we do try to perform. We do I remember the approach remains same as the supratentorial gliomas as far as the clinical part is concerned. But yes, it's very they are very few in our clinical practice.
Yes, and fortunately for us, at this time, for treating brain tumors, we don't have many options.
But yes, the molecular characteristics help us to decide the kind of the treatment option that one has to choose. Yeah. And that is where the world is moving forward. At one point of time, we were actually not using IDH sequencing at all. We were just labeling the patient, leaving it at wild type IDH. But now we are finding that, yes, there could be patients who are like IDH wild type, and still in sequencing, you'll find a mutation type. All those things, ma'am, are, yes, changing our management, line of management, prognosis, MGMT methylation, yeah, using testing them for EGFR, and all these pointers, they are making difference to the clinical practice. And yes, the co-deletion 1p19q. So there are a lot of labs also which are coming specifically with the next generation sequencing panel meant for only CNS tumors. And that is also we are incorporating our clinical practice to decide, especially the second line, third line management. Yes. So I think we have more questions here.
Yes, Dheeraj Gautam, I know we do get a lot of frozens, and we do grade them on frozens. What we do, we always make a squash and an imprint and the sections, and always correlate with the radiology. We communicate with our radiologist during our frozen before we give a diagnosis. But I find that the squash and imprint do help a lot, because quality of frozen section varies from person who is cutting. Good technician gives you a very good section, but sometimes if that good technician is not there, then you can be in real problem. But what I always look for on a frozen section is necrosis and endothelial proliferation and mitosis. Look for mitosis. They can be difficult, but yes, we do look for them.
Can I?
Dheeraj, yes.
Yeah, ma'am, it's a very nice lecture. And my question was not there. In view of topsy-turvy of neuropathology nowadays, every day it is changing. You know, initially 20 years back, we used to grade it like grade 2, grade 3, and grade 4. My question here is, with the molecular coming is, can we grade it only high grade and low grade, rather than grade 2, grade 3, and something like that?
No, see, frozen section.
Because clinician, the surgeon is more interested whether it is high grade and low grade. If it is low grade, then yeah, isn't it?
Yeah, Dheeraj, in frozen section, I'm not going to spend 1 hour and also to give a complete diagnosis. Most often they are interested whether they are in the lesional area, especially when it is
exactly.
So,
exactly.
So I tell them, yes, you are in tumor. And then if I am able to say, this is a tumor which is showing necrosis and it is showing microvascular proliferation, then we tell them that. And also many times I tell them that I don't think it is a glial tumor. Only this much, not
Yes.
more.
Yeah. Okay. Okay. Perfect. Thank you.
Ma'am, there's another question by Dr. Rahil.
The first diagnosis on left shows Idh mutant ATRX absent, CD retained to be grade 2 or 3, CD it be graded 4 2, especially if it has microvascular. If it is IDH mutant, ATRX absent, CDK2A to be retained, it is grade 2 or 3. Yes, it could be grade 4 if you are seeing microvascular proliferation and necrosis. If you see that, then whatever marker is there, whatever cellularity, mitosis, it will become, if you see these two morphological features, it becomes grade 4. It can still be grade 4.
Okay. Okay. Thank you, ma'am. Thank you.
And there's another question on the group. Maybe you can take this one also on the WhatsApp group. Recently, I have case of grade 2 astrocytoma asked by Dr. Kanchan Joshi. I'm doing IDH, ATRX, P53G, GFAP only. So should I report it as astrocytoma grade 2 NOS type?
Why, if you can, if suppose this is an IDH mutant glioma, then you can say, yes, it is an IDH mutant glioma with, yes, if it is, then you can say that histologically, it is grade 2 or 3, and we need to do CDK and 2A, 2B for excluding or for proper grading of the tumor, which is now required as per the WHO recommendation. You can write it like that. Histomorphologically showing grade 2 or 3 needs to be, this grading needs to be properly done by doing FISH for CDK and 2A and 2B. That is how we also write. We wait for the CDK and 2A, 2B FISH report to come, which is a little faster. It takes about 3 to 4 days only, and then we report.
So I think that will be all. No more questions here.
Yeah. Are you doing? Yes, we are doing. We are doing CDK and 2A, 2B by FISH. We have the full panel of investigating or practicing CNS 2021 WHO. I belong to SRL, so you all can send to SRL there. We have our molecular lab in Mumbai. We have NGS. We have IDH, MGMT, 1P19Q, CDKN, 7 and 10, EGFR, TART mutation. We have the full spectrum, full blast. And it is quite affordable, not like NGS where you have to pay 60, 70,000. No, I think it is about 20,000 or so. You can find out from the SRL. We are doing it.
Exactly, ma'am. The important thing is that one need to find that, yes, what needs to be done when. That is the single most important part of the neuropathology. This is what comes out. This is what needs to be done. So the awareness is still, I think, lacking, but I think we are helping there to fill the gap. So I think we'll wrap it up here, and Dr. Anila will take it on the 28th, isn't it, ma'am?
Yes,
Yes, and Dr. Gaurav on 29th.
yes.
Yes, okay.
Dr. Anila will do the circumscribed gliomas,
Okay.
and Dr. Gaurav will cover the glioblastoma.
Okay, oh, that's one of the most interesting topics for us. Okay, thank you, ma'am.
Okay,
Thanks a lot.
bye.
Everybody,
Good
good
night.
night. Yes, thanks again, ma'am. Thanks for a wonderful presentation. Thank you, everybody. Good night.